Hello, and thank you again for joining me today at Breastfeeding Q&A. It's a beautiful day here. We've had some cold weather and lots of rain, but today is absolutely beautiful, a good day for breastfeeding questions and answers. Thanks for participating. I have to start by saying, please understand that because I don't have a detailed history from everyone that asks a question, because I can't observe a full feed with looking at those particular points in your question, it's important to me that I answer your questions in the broadest possible sense. I can't do it in the detail that I would if I was sitting beside you, observing, and have had taken a detailed history. But I will do my very best to answer your question. The first question today is one that comes up. I will be looking a little way at times because I'm reading the questions. It comes up quite commonly. So the first question today is about how long is the rest and digest period for? There's, in my experience, I have to speak from my experience because it may be different for different people. It may be different for different professionals. But in my experience, the rest and digest period that I have practiced with women for many years, there is no time to it. A whole feed takes for a small baby, about 1 hour. And so the baby feeds from one breast to satisfaction, and that's satisfaction with gastric volume, making the baby drowsy and sleepy as its stomach fills. And then it stays and nurtures for a little while, and then it slips off. And when the baby's slipped off, that starts the rest and digest period. So then the baby may rest out on your knee, preferably on your knee, because if you hold the baby up right here now and snuggle up with it, what happens is they often go off to sleep. And then you think they're asleep, and then in an hour and a half, they're awake for the other side. So if you put the baby out on your knee, however's comfortable for you, with the ability for the baby to be able to stretch out. So what happens is when they've had a little rest on your knee, they start to stretch out and often lift their arms above their head. And you'll see them stretching out the middle of their body. So that then allows enough room for the diaphragm and the stomach to be relieved pressure from each other. It allows the air to rise. And when the air rises, the baby's much more comfortable. The baby will burp by itself. You don't have to hold the baby up or sit it up. If you sit it up and hold it here, it's curled in the middle. So it's really hard for the air to rise. So that's part of the rest and digest period, is to let the baby stretch out nice and as often as it needs to. So then the finishing up of the rest and digest period comes with the baby's cues. So the baby's cues are to go back to the second breast, and then you would fit a nappy change in somewhere there too as well. But the rest and digest period cues are babies changing in body language and changing in facial expression. So sometimes the little baby will slightly lift the head as if it's trying to come to you, maybe turning to look at you, turning the head, and maybe using the hands and legs and feet. So that's the crawling, walking, reflex working with the feet and the legs. It's the touching, feeling, sensing with the hands, wanting to come to you. And then you'll see the tongue protruding. And as the tongue protrudes, the more the tongue starts to protrude, you'll hear the voice start to kick in, and you might hear a little sound, and then you might hear a little louder sound the longer you let it go. And if you really want to test it, you'll hear the baby telling you it's time for me to feed from the second breast. So the rest and digest period doesn't have a time to it, but if you wanted me to say, approximate, it probably would be 10, 15 minutes, but by timing it, you're missing out on the baby talking with you and talking with you about what the individual baby's needs are, because they're all different at different ages, at different stages. So the tiny baby, of course, may take a little bit longer, but that's okay. While that's happening, the enzymes have curdled the milk, transferring it pre-digested into the intestine with what we call a peristaltic wave. That's from the tip of our tongue to our anus. It just keeps continuously working. And it moves the food or the milk through the breast through the stomach into the digestive system, pre-digested into the intestine. And when it's pre-digested in the intestine, then the next part of the digestion takes place in the intestine. As the stomach level drops, that's when the baby's cues start to become noticeable. So the volume in the stomach gradually drops while the transfer is taking place. And it's just a patience, it's just an enjoyable time. It's not rushed, it's gentle. Everything we do with a newborn baby and a young baby must be gentle. It's not rushed, it's not hurried, and it helps you feel calm and it helps you understand your baby. So the rest and digest period is a common question. Lots of people ask that one. There is a video clip too, I think, that covers that as well. Kelly will put that up. I'm sure she'll put the link up for that. So the next question is from Shani. Shani says, I was wondering how it feels to fall pregnant while you're still breastfeeding. Do you have all the same symptoms? Do your breasts hurt? Can you still breastfeed your baby while pregnant? Well, let's start from the last part first. You can breastfeed while you're pregnant. Many women breastfeed while they're pregnant. But what happens with pregnancy is there's hormonal changes going on, which may alter the prolactin oxytocin from the pituitary gland, and it does increase estrogen, progesterone. So you might find that milk volume might change. You might find that the taste of the milk might change. You might find the baby's behaviour might change for a period of time. It's not a set period of time, but you might find that will happen. Do your breasts hurt? Well, it depends. Your breasts have already been filled with milk over a period of time, so they're not expanding with pregnancy in the same way as they did before. They may hurt, they may not, and that could be hormone related. And again, it's individual. And the other part is when you fall pregnant when you're breastfeeding, you might find that there's no real answer to this because everybody every mother will feel different. I don't know, without thinking about it way back, how it feels to fall pregnant while you're still breastfeeding. I think what will happen is your maternal instinct will guide you. You will know how you feel as an individual if you know you're pregnant. If you don't know you're pregnant, you'll just carry on, and there'll come a time when you do know you're pregnant. And there may be changes, but if you just relax and go with the flow, watch your breastfeeding baby and see what the behaviours are, I'm sure that your instinct will guide you all the way. Tune into that instinct. It's so important. Thanks, Shani. I hope I've answered that okay. But the problem is there's no one set answer for every mother's individual. That's the most important. This is from a mother. I'm sorry, but I don't have her name, and she might like to put it up if she's watching, and I don't mean to be rude. That's really important. But she says, I had my baby girl 4 months ago. She was an IVF baby, and she had this little baby via cesarean section. I'm breastfeeding her at the moment, and I'd like to continue breastfeeding her until she is over 1 year old. That's brilliant. That's absolutely brilliant. I have one more embryo left, and I would like to use this. My question is, I have my embryo that I have saved, transferred a year later. Can I have my embryo transferred a year later and still breastfeed my 1 year old? Or will I have to stop breastfeeding to have the embryo transferred? My thoughts on this are, I'm not an expert at this. I really need to say that I'm not an expert with IVF and that time frame with breastfeeding, but it depends on the drugs. It depends on the hormone changes that take place. If there's any drugs being used, it may affect. If there's any hormone changes, it may affect breastfeeding. But I would say that you don't have to stop unless you're advised to by the professionals who are expert in this area. So I would talk with them, I would have a plan with them and say that it is your desire to continue breastfeeding and see how that plans out for you. And please share it with us if that's all happens in the way you would like it to do. And if it doesn't, I suppose it helps other women be informed too. And keeping in mind that everybody is different and every transfer might be slightly different too. So, but I would suggest that you continue breastfeeding and at the same time talk to the professionals that are helping you. So thank you for your question. The next one's from Tina. Tina says, my 7-week-old daughter hasn't been eating normally. I am breastfeeding, but she hasn't been wanting to feed for at least 2 days. Now, I'm not sure how long ago this was, Tina, so it might be several more days by now. She has to be very hungry before she wants the breast. Well, she's 7 weeks old. So my first question to you, has anything changed in the time that she hasn't been feeding as well? Have you added anything to your eating, to your drinking? Have you added supplements? Are you swallowing any supplements? Or the other question that might rise is have you started any contraception? It's probably a little bit early for that, but I don't know. Has your baby been sleeping longer hours at night over that several weeks? And if so, you could be ovulating. That's another thing. It's a bit early, but it does happen. So the other thing to consider is the she really hungry before she wants the breast? That sort of says to me that there's something coming through the milk that she really is. If she's got a fussing behaviour, if she's turning away, refusing, and if she's behaving in a agitated way, it tells me that there's something that she doesn't like in taste or smell coming through the breast milk. And the other thing would be if the volume was so high that it's coming so fast that she doesn't like that sensation of the milk spraying rapidly over the back of her throat and trying to control that with her draw-swallow rhythm. But I think that doesn't sound as, to me, as if, I just would love to have a little bit more history. I hope that helps you, Tina. Just to take stock, write down maybe if there's anything that you've changed that's a common denominator that's happening every day in the last few weeks that may be, and then you eliminate it. Of course, you don't eliminate your contraception. You've got to wait patiently for that to settle down. But you eliminate one thing, or you can eliminate it all and then add one thing at a time till you see the baby's reaction, see if there's any reaction to that. I see a lot of babies reacting to a whole range of things, and including the lowering of volume when contraception starts too. So hopefully that'll stimulate enough for you to be able to have a look at yourself and your baby and see if there's something very individual that's happening that's a common denominator for you. Thank you. Next question is from Joe. Joe says, I've recently had a preemie at 33 weeks. Noah is now 5 weeks old. How beautiful. 38 weeks corrected. Didn't I answer this one?
No, she's on.
Online now? Okay, so it's the same question as someone else has asked then. We were given a nipple shield by the lactation consultant at the hospital, which works well, as without it he struggles to hold the nipple in his mouth. So
she wants a recommendation on transitioning away from the shield.
Okay, so you want to slowly transition from using the shield, as I understand it. So babies get very conditioned to using whatever's been in their mouth because their oral cavity, the muscles, the tongue, the vacuum, everything centres around what they've gotten used to. So we just change that a little bit at a time. So the ways that I suggest if you are using a nipple shield is to is to maybe slide it out when the baby's a little bit settled after getting some milk in the tummy, and see if the baby will start coming to your nipple rather than the shield, because the shield's forward in the mouth, so it only comes to about the first joint on your little finger. So it's only working forward in the mouth. What we want the baby to do is draw your nipple and some breast tissue way back to the soft palatal cleft. So the nipple goes to the soft palatal cleft, and the rest of the breast tissue forms the shape of the baby's oral cavity, and it's the perfect fit. Whereas now we're using anterior tongue, anterior mouth, and not getting the same vacuum and the same distance, the same function of the temporomandibular joints as you would if the baby was using the breast. So slowly, gently, no rush, and certainly no pressure on you, because if you start putting pressure on yourself, it becomes stressful, and then you produce adrenaline, and then you get stressed, and everything's all over the place. So very gently, and at times when you can, have the baby with just lips over nipple, when you're both quiet together, and let the baby try and work it out, lips over nipple. The other thing is to express the milk from the nipple each feed, so that you're expressing your breast, actually, not the nipple itself, but back at the areola. And there's a video clip, a link to that, to show you just how to express, but express some into the baby's mouth, so there's a message to say the milk is coming from here. And often they'll start using their oral cavity in the way they would have at the time of birth. So slowly, gently use the... It's hard for me to answer it exactly, but 33 weeks, now 5 weeks old. So getting to 5, 6 weeks old, I would be just offering the breast as much as you can each feed, very gently, expressing some milk into the baby's mouth, so the baby realises that milk comes from there and starts to lick, starts to put the tongue forward, starts to use the lips over the nipple and sealing the breast with the lips. Just getting used to all of that first. And if the baby doesn't feed, of course, let's finish the feed within an hour, because we don't want one feed running into the next. We want to aim for about 7 feeds in 24 hours using both breasts. So it's really important to not try so hard that your baby's timing with feeds is interrupted as well. Please let me know how you go. Thanks, Joe. Next one's from Chelsea Deacon. Chelsea says, I'm delivering my second baby this Saturday, June the 30th, an end of financial year baby. That was 2017. So Chelsea said it's got 2017 via cesarean section, Chelsea says. So that would have been, meant to be 2018, yeah. I think. Yeah. I think it's meant to be 2018, yeah. My first child was born May of last year in an emergency cesarean section, and was with us for 4 days. Oh, I'm so sad before passing on. It's a traumatic time. Since I became pregnant so soon after my first, my doctors recommended another cesarean section again to avoid complications and added risk. So I am less likely to experience the heartache of bearing my child again, of losing my child again, I think that is. My question is, as this will be my first time breastfeeding following a cesarean section delivery, will I be able to nurse my baby within 2 hours after delivery? Well, let's do that part first. If your baby's APGAR scores are 7 or above, you should be able to have your baby on your body, if you've set that up with your team, your surgical team, from before you have your baby, have a plan and work it out with them. And as long as the baby's fine at birth and the APGARs are 7 or above, baby on your body, your warm body, covered with a warm blanket, not rubbed, handled or touched by anybody else, just straight to you, would be the best possible outcome you could have. Gentle, gentle, gentle. Little babies need gentle. They need to be transferred to you gently, handled gently. So So what will happen then is, in good time, the baby will start its searching, seeking, smelling, tasting, touching. So not to be rushed. Just having the baby lips close to your nipple will be a good start. So the baby can do all of those things once it's secure with you. Secure is really, really important. The things that might make it more difficult might be the drugs from the section. So if you've had opiates, which you will have had during that time, and if you've had an epidural, it will be opiate derivatives. So you might find that if the baby's a little bit sleepy, it won't make the effort, and that's quite normal at that stage. So to overcome those sorts of things, what I would suggest is you express some breast milk using the video clip that I have on expressing, which Kelly will put the link up, and start collecting some of your milk, your colostrum, before the baby is born, and then that can be your baby's first feed, which will bring the baby's glucose levels up, with blood sugars up, which will mean that you've got some space to get some help to express your breasts on a regular basis, frequently, for about 2 to 3 hours. You know, have a rest, express, have another rest, express, and get someone to help you so that you're in advance and you're giving your baby your colostrum right from the start. I call this simulation. We're simulating what the baby would do under normal circumstances if the baby doesn't feed immediately, in the first couple of hours of birth, 2 to 3 hours. So that 2 to 3 hour period is what the baby would do. It would feed leisurely, it would stop and look, it would feed again, it would swap breasts. So we want both breasts to be expressed. We want that colostrum reserved and given to your baby. And then have a long rest where the baby would normally go off to sleep, and you'd have a long rest. And then what would happen is you would start the process of expressing more frequently, up to 72 hours. So expressing frequently means, you know, the baby comes to the breast, feeds, has a little rest for a while, comes to this, breastfeeds, has a rest for a while, and it keeps doing that right up to, as the milk increases, right up to about 72 hours. Not exact, but about between 72 and 96 hours. And once the milk's peaking, that's when you change and you go to one breast, rest and digest, and then the other breast. And that's all on the video. So if you follow that video, it should help you get to that point. And then you start on the breast that you finished on last feed. You start on that one first, this feed, because as the baby gets more into breastfeeding, it takes quite a lot from one breast. We don't know how much. Some from the other. So next time you start on this one, and that generates your milk volume, keeps the milk volume regulated. Very important. I'm just getting some help here to answer, see what else we have to answer.
Just checking if we finished with that.
No, not quite. I'm talking online because there are curious things about different. 72 hours, feed smoothly, and yep, I think we've covered it. And if you've got time, I know it's getting close, but if you've got time to have a look at the video, if not, see if you can look at it when you've got some time in hospital. But certainly, the most important thing is for your baby to come to you from birth, if possible. That no one else is rubbing it, touching it, handling, doing things to your baby that are not urgent or emergency necessities. Very important. So talk to your team and see how they go, and let us know. We'd love to hear. Thank you.
This is Kate. She's online.
Okay. Hi, Kate. You're online, I'm told. That's nice. You're a first-time mum, and I'm wondering if you would have any recommendations. I have a fast flow and currently only feeding off one breast as baby gulps the milk down. Gets bad wind from the air gulping, and as I feed both, he will throw everything back up. I've tried lying down, feeding nipple shields to slow this flow, What would be your advice? Okay, Kate, that's a good one for me. I can probably answer that almost without having a detailed history and almost without seeing you feeding. It is hard, I know, and when the babies are like that, it's quite distressing. So what is happening is your little baby's feeding high volume, fast, over-expanding the stomach, and then is very unsettled. So that rapid digestion is pushing through the system very quickly, and then it comes out very rapidly the other end, and they suffer from colic, and they suffer from the reflux that goes on with that. So my suggestion is to you to start now on the softest breast first. So that will give the baby an amount of milk to feed to satisfaction. When the baby drifts off or comes off, little time to rest and digest till the baby asks you for the second breast, then your baby will take some off. It probably won't be able to, we don't drain breasts, in other words, because the more you drain them, the more you generate more milk. So we want the baby to feed so that it makes that breast comfortable. And then the next feed, start on the softest breast again until you feel that full breast, that from one-sided feeding is now feeling more, till your breasts are feeling more comfortable, much more comfortable and more regulated. And then stay with two-sided feeding. Now, what's important over that time is, because you'll have a full breast, is to be aware that you need to make that breast comfortable, the one that's the fullest, comfortable all the time until this regulates. So it may mean that you'll need to express a little bit off, but not a lot. The important cue is comfort. What's comfortable for you when you feel your breast? You think, oh, a bit hot and cold. I feel, oh, I don't know, this is a bit full. So then you just take enough off, and then you feel again. And when it's comfortable, stop, because if you keep going, you're just going to generate more milk. So the aim is to, first of all, slow and regulate the volume, then slow the baby's digestive system. And then when you're feeding two sides each feed, the baby feeds only to satisfaction, to capacity, to emotional satisfaction, then has time to rest and digest, and then goes to the other breast. I hope that helps, Kate. I hope it helps. Next question is from Rosanna. Rosanna says, my first child, I breastfed until he was 1. No dramas. He was a hungry boy and fed all the time. He would take the breast every time I offered. My second child, she's 11 weeks old, and some days will go for 4 hours without feeding. She still only takes one side at a time. She's sleeping anywhere between 4 to 8 hours a night before waking for a feed. If I try and latch her and she's not hungry, she loses the plot and screams. She's growing and she seems happy. Should I be concerned that she's not this major booby monster? How many feeds should she have in a 24-hour period? I would say to you, Rosanna, if there's no problem, don't be concerned. If things are working for you, we don't need to change it. All of my work is based on women who come with a complication. So, and all of my research was with women who had complications. So if things are working for you and you're getting 4 to 8 hours sleep a night, and you've got a toddler as well, a young one as well, then please don't change anything. The only thing with one-sided feeding to be aware of is, in my experience again, that by 3 months, maybe 4 months, the milk volume actually does sometimes reduce, because only one breast is being used per feed. But I really think that in your case, don't wake her. But if you have uncomfortable breasts again, it's really important that you express some of for comfort if she doesn't want to take it, because we don't want you to get pooled milk, we don't want you to get a blocked duct, and we don't want you to get mastitis. And sometimes if the milk stays there too long in that pooled state, it thickens and then the problems start. So just be aware of that, but it seems like you're not having a major problem. So please, use your instinct. It'll always guide you. It'll never be wrong. Your instinct will always be right. And it seems like your baby girl's not worried about having a full breast each feed. But if you have a problem with it, or it starts to be a problem, then you know. And the video link that's going up for Kate may help you too. So I'm hoping that will be of help to you. This is a message from Hoodster. Hoodster says, my son was diagnosed with a tongue tie, but far back on the tongue, and was advised it won't affect him in the future, so they chose not to do the correction, as there was no guarantee there would be any improvement. The problem is that he continuously clicks while feeding, and I can't seem to express much milk at all to give him a bottle, but even then he clicks a lot and gets a lot of air, which makes him really gassy. Any suggestions how to get him to latch on better, because he can't seem to latch beyond my nipples? Now, I'm one of the professionals that says leave well alone, that tongue ties and lip ties are not things that I genuinely rush into, and I have had reason, but very limited reason, to recommend to have these, have an assessment at least by an expert in whether these things need doing. If you've had an assessment by an expert, then it would seem that you don't need to do anything. The question I need to ask you, if the baby's clicking, it's also common to make a clicking noise if the milk's coming fast, or if according to the teat, if you're gravity feeding, then that may be, or the shape of the teat. So if it's a small nipple teat with a wide base, the baby won't be using the tongue as much as it could with a long, narrow teat, where the baby actually draws. Now, if you're putting the teat in, that makes a difference. If the baby's drawing the teat in itself and working, that will be preferable than you putting the teat in and gravity feeding if you're using a bottle. And it looks like you haven't done that yet, but he won't take a bottle. And it's probably because he's used to your breast. He's not happy to exchange between breast and bottle because they get used to the oral cavity. So the questions I would ask you is, when you're feeding, have you seen my video clip on face to breast symmetry? Is your baby facing your breast? Is your baby lips to nipple? Is your baby drawing the nipple and the breast himself? And is your baby symmetrical when he's on the breast? They're the important things. And then that gives him more oral potential if he is. If he's not, then maybe if you have a look at the video on this that I talk about, because if he's feeding forward in the mouth, it may be to do with the tongue, but I've not had those sort of problems with the babies that have had tongue ties in my practice. It may be that he's just not drawing the breast and he's not symmetrical at the breast when he's feeding, and maybe he needs a little bit of fine tuning. So if you have a look at the video clip, if you've got the time to do that, and maybe get back to me and let me know, or let my team know how you're going, and then we can talk further about what might be able to help him with his clicking. But the most common thing for clicking in my experience is the volume of milk coming too fast. And if it's coming into the mouth, the baby's trying to control the flow with the anterior tongue to the roof of the mouth. So I hope that works for you, Hoodster. Could you please let one of the team know so that we can consider it further if you think that might be an issue that's continuing for you. Now we have a question from Anna. Anna says, I'm going to have a 10-year gap between my firstborn and second. With my firstborn, one of my breast milk dried up, one of the milk in the breast dried up. I managed to keep feeding him until 17 months. How can I be sure this won't happen again? Wow, what an amazing job you did to feed him for 17 months. That's brilliant, Anna. Okay, let's see. you're going to have a 10-year gap between your first and second born. Well, you're really starting fresh. You're starting on a whole new journey with a second little baby. So it's really important right from the very first breastfeed. The first 72 hours is critical to continuing breastfeeding in the long term. So please, when your second baby is born, to be sure that your baby is with you. APGAR scores above 7, your baby is on your body, covered gently with a warm blanket, not a great big hat on to start with, just as natural and as simple as can be, but kept warm. And what happens is the cover on the outside absorbs any moisture off the baby, so you're not rubbing and touching and anybody else handling the baby. That's the first thing. Then the next thing is to just gently wait, be comfortable, work with your midwife on what's most comfortable for you, and watch your baby's cues to breastfeed. If there's been no opiates involved in your labour or your birth, then your baby should be alert and looking. APGAR scores up, should be looking for your breast within a reasonable time. Sometimes they take up to an hour to go to the breast, occasionally a bit longer, but in my experience, when they're just on your body and they're gently with you, then they'll start working towards the breast. Depends how you're lying, how you're sitting, where you are, how they start to make their way, but they come to move their way down to the breast. Lips over nipple, face to breast symmetry, and then start that first breastfeed, which may be leisurely over 2 to 3 hours, so you don't need to be interrupted in that time. If people are coming and interrupting you, that doesn't help at all. So if your midwife can just arrange for you to have quiet space and for her to be around, maybe sitting beside you some of the time, just watching, baby lips over nipple, baby coming to the breast by itself when it works it out, and then making sure the baby's symmetrical at the breast right from the get-go. And that will make a huge difference for you. Then when the baby's finished on that side, we'll go to the other side, and that might just continue on, not all of the time, just leisurely, up to a period of about 3 hours. And then what happens is the baby goes to sleep, has a sleep, and without being handled by a lot of people, just cuddled up, nurtured, and as close to you as possible. And then you will have something to eat, you will have a rest too, you might have a shower, I'm not sure what the situation will be, but you will then have a nice long rest as the baby sleeps, and then when the baby wakes, the baby will feed frequently from each breast, bringing down colostrum, increasing hormones, and as the hormones are increasing, the milk volume is starting to rise, and the milk volume rises over about 72 hours. So we don't expect the baby to have big feeds, big volume feeds in that time. It's gradually increasing, and you watch the baby's output and you'll see the output increasing. You'll see the colour and the consistency of the poos changing as that cycle begins to happen. And around about 72, 96 hours, the milk volume in your breast now, the hormone levels have helped the milk volume reach a peak, and that's when you go to two-sided feeding. So you feed from one breast, rest and digest, nappy change in the middle, feed from the second breast, and then rest and digest back up here again, snuggled up so the baby has the opportunity to snuggle into you. It's still extended in the middle because it's elongated on your body, and then once that digestive process is calmed, the baby will go off to sleep. And then the next feed, start on the breast. You've finished on this feed. If you forget, don't worry. Just go to the softest breast first. And let's see how that cycle goes for you. And let's see if both breasts will fill. If there's no abnormality of your breast of any sort, then your breast should fill. Thanks for your question. Now we're going to Vicky, is that right? Mm. Vicky says, I'm wondering about my 3-week-old baby. He only seems to want to eat from one breast for about 5 minutes at a time. He doesn't seem to be hungry when he comes off. He's usually very sleepy, if not actually asleep. He is doing wet nappies. He's put on weight. I was wondering if that's okay and any tips. It's fine if there's not a problem for you, but you will find that gradually it will work, that he'll probably go to both breasts. But if he's been coming to one breast each feed right from the beginning, he's coming to a very full breast. And by coming to a very full breast, that's overexpanding his stomach. So again, gradually go to two-sided feeding. You don't need to rush, but if you can do some feeds where you do both breasts. So what that does, when you do both breasts, he draws down an amount that's not going to be so high volume in his stomach. And then he'll have a rest and digest period, and then he'll ask you for some more from the other breast when he's ready. And I think we covered that earlier in the session, didn't we? So if you go back to the beginning of this session, if you're watching it later, you'll be able to see that cycle is so important. So again, Chloe, if you're not having a problem, am I with? No, I'm with Vicky. Is that right?
Yeah.
Sorry, Vicky. It's a little rolling down. I wouldn't be in a hurry to change too much. And yes, he will be satisfied and he will be putting on weight because the volume is good each feed. But it's not a long-term thing as I see it in my practice. The longest term thing is to feed both breasts each feed, and that continues and sustains your breastfeeding much longer. So let's see how you go. Thank you for your question. This next question is from Chloe. How do you encourage a baby to stay awake during a breastfeed? One of my twins loves breastfeeding, but I'm always nudging her to stay awake. Even if she's already had a nap prior to the feed, the same thing happens. It's like she just gets too comfortable and goes to sleep. So I suppose, is she getting enough volume when she's feeding like that? Is she efficient at the breast? Is she symmetrical face to breast? Is her wheeze and poos, her output good? Is that consistent with what she's swallowing? Is she weight gaining? I mean, sometimes twins aren't the same, so one might gain more than the other. So there's a whole lot of questions that come around it. If she's a happy, satisfied baby, then she's probably okay. And she might be feeding differently to the other baby. And the other question is she feeding more frequently because of that too? I'm not clear on what the history of it is. But it's a little baby boy. He's doing wet nappies and he's put on weight. So I'd say possibly the question is, are you feeding them both together at the same time? And if so, are you swapping sides? Because if one baby is more efficient at making the volume of milk in your breast, then that benefits the other baby and that keeps the milk regulated in both breasts as well. So that's another little thing to think about. But if she's going to sleep and she's growing and she's doing all those things, I don't think you've got anything to worry about. I think all of those things are being met for her particular needs. But keep an eye on things. You will always know. Your instinct will guide you. And if you're trying to get them to feed together, that might be, you might have to work through that. I don't know whether you've got one little baby on each breast and then the next feed you swap them over. Thank you, Chloe. Now this is from, Vicky. Sorry, Vicky.
No, that was Chloe.
Oh, was it? It is, sorry. Now let me get this so I'm not, and this one's from Angela. Okay, now I'm better. Now I've got it. Sorry, girls. Angela says, do things I eat affect my baby? I had a weight loss shake and all he did was vomit the whole day. Been a bit scared to start again, just in case his tummy was not coping with it. It is a common problem, Chloe. Angela? Sorry. I've got to look at this. Okay, I've got it. Angela, it is a problem when when you are, and in my experience, it's been a problem for many years for mothers who are swallowing substances like that. And the babies often fuss, they breast refuse, they will be sick, they're often vomiting babies, and read the labels and see what the content is in what you're swallowing. It will come through your breast milk, and it's generally about 6 to 8 hours after you've taken it, according to the research. So there's a research article from Denmark that talks about how long it takes to transfer. So see if there's a pattern to when you're taking it, to when this is happening with your baby. If you're taking it every day, it's like, or more than once a day, there will be likely to be a flow-on pattern from it. So I would definitely think that that's probably the reason. My question to you is, do you really need to take this? Do you really need to take this while you're breastfeeding? If you don't, are there other ways? And if I had the time, I'd love to sit and talk with you. Are there other ways that you can consider? It's obvious that you're wanting to lose some weight, or you're wanting to do something for yourself that may be affecting your baby. Are there other ways you can go about that? Ask yourself that question. Let's see how it goes, and please let one of my team know if you have the time to do so. Now, that was Chloe.
That was Angela.
Angela. All right, so I need to move up like this, so I've got, that's better. So I've got Ashley now, right?
Yes.
My 4-month-old is still not feeding 100%. She has never fed right since day one. She has just had a posterior tongue and upper lip tie released 1 month ago. She is now staying on the breast but is pinching me. How can I get her to open her mouth as wide as possible? I generally don't work on opening mouths as wide as possible, Ashley, because the babies actually vacuum. So what they do when their lips are over nipple and the tongue protrudes, they connect with the tongue connects with the nipple, and the vacuum pads inside start to build up the pressure. And as the pressure builds, they draw the nipple and breast tissue all the way back to the soft. Nipple goes to the soft palatal cleft, and the rest of the breast tissue molds to fit the oral cavity. So it's really important that you don't need to actually open the mouth wide. It may be that the baby's asymmetrical at the breast if the nipple's pinching, and if that's so, it's probably one cheek off or the other cheek off, or the baby's back from the breast a little bit, so it's only nipple feeding, not breastfeeding. So if you look at the video clip, if you have the time, please look at the video clip on face to breast symmetry. So important for best potential oral cavity function and the baby's ability to draw all the way back, and to mold your beautiful nipple and your breast tissue to the individual shape of the baby's oral cavity. Very important. So
it's Ashley still.
You're still on Ashley. So you can do little exercises, drawing down on the chin to open the lower jaw. Stretch the temporomandibular joint in between feeds when the baby's awake and you're playing. And so it's really, really, really important not to get hung up on all of that, though, to just continue on with what you're doing. And see, I think the pinching could most likely be from being offset at the breast, not being symmetrical at the breast. And also, it's possible the baby's still adapting to having those little stabilisers cut. When these are cut, they stabilise lip to gum. So they have to relearn to use all of that area of their mouth, top and bottom. And under the tongue, maybe still sore, I don't know. But they're things that do occur with little babies that are having all these pieces snipped. So they're not things I encourage, and I would work with you most definitely in a different way from the outset if that was the case. and would give it good time to see how it works. So let's see if by face to breast symmetry, if that makes a difference for you. Now we're up to Kat, is that right?
Yes.
When I feed my baby on the right breast, Kat says my baby makes a strange noise each suck. It's like blowing raspberries on my nipple. It feels like he's dragging my nipple and breast, and sometimes it can be painful. No nipple trauma visible, though he is draining the breast. Okay, he's 9 weeks old. The left side is fine, and he self-latches. So we don't need to worry about the left side. It sounds like it's the right side we need to focus on. It's worth noting my breasts are very different shapes. The left is smaller and the right is much larger, with the nipple pointing down. I have to shape the breast on the right side. All right, so my most common experience with the sounds the babies make in the mouth is that they're either not using oral cavity to full potential, or the milk's coming fast, high volume milk coming very fast, so they compress the nipple into the roof of the mouth to try and slow it down. Nipple and some breast tissue sometimes, and so that tries to slow the flow down. So I'm not sure what's happening there, but certainly if your right breast is larger and your nipple is directed down, the aim would be just gently and very ineffectively is to, can I show you my breast? Is to take your finger as the baby goes on and just lift so the nipple straightens, it's not down. You could use a totally different aspect and come from underneath up, so you're following the same angle as the nipple, lips over nipple, but that's sometimes a bit awkward because it's closer to your knee. So by just redirecting the nipple very gently so that the nipple comes straight as his lips come over the nipple, and holding it there till he's actually starting to swallow. So you can put your index finger on either, on the right side. This is my right side, and just keep it redirected like that until he's actually swallowing, until he gets used to that. The other thing is, if you think that breast is a bit too low, then what you can do is roll a little face washer or a small hand towel, something that's not too big and bulky, but put it underneath the breast just to lift the breast, and that may straighten the nipple. I don't know. And if you are reshaping your breast, that's okay, but you need to keep the reshape so the nipple is straight. So not too far up, not too far down, so that it's straight, and keep the reshaping there again until the swallowing starts. That means the milk's squirting out of the nipple and it's flowing over the back of the throat. Very important to maintain that. And let's see if that works for you. I think that will probably help you. Just focus on that each feed, Kat, and see how you go and let us know. Thank you. And now we've got, is it Emma? Yeah, okay. Hello, Emma. Just wondering how long it generally takes for a fast flow to regulate. It depends where you are in your feeding cycle. It depends, are you feeding both breasts per feed? Are you feeding one breast per feed? I don't know much about what to do, but if it's from birth, your milk will start to regulate around the 3rd, 4th week if you're feeding both breasts, each feed, from about 72 to 96 hours, when that milk volume peaks and you go to two-sided feeding. And the rest of that's been covered at the beginning of this session, so you'll see other women having similar questions with a similar answer, and so I would say, and unless you're taking something or swallowing something all of the time, every day, not all of the time, every day, that's a common denominator that may be making rapid milk flow, that may be another issue, something that might need considering. Fast flow generally comes from one-sided feeding. So let's see, Emma, how that goes, and please feel free to let my team know how you're going. I like to make sure that I'm not letting anybody down by not covering everything that we possibly could, but again, I'm covering it in the broadest possible sense at the moment. Next one is Chelsea. Chelsea says,
this may be the last one.
Can you talk about different nursing positions? Is it recommended? Can you just ask the background noise to stop, please? Thanks. Can you talk about the different nursing positions? Is it recommended or not? I know you should avoid the cross cradle position, but there is other positions like the football hold, etc. I've even heard those different positions help release the milk from other ducts so that the breast is getting fully expressed. Is that correct? Chelsea, look, I don't say don't use the cross cradle technique. I'm saying from my experience, the reason that women, statistically significant outcomes for women who are using the cross cradle technique and nipple trauma, breast engorgement and mastitis were the most common things that I was seeing. So nearly everybody that comes with a complication of some sort. So that was the most common of them. So, you know, if it works for you, as long as the problem with the cross cradle hold is we're holding the baby at the base of the skull. Just under there is the small brain. The small brain is what coordinates the baby's movement. So if you're interfering with that part of the head and the neck and the brain, you're interfering with what the baby's capable of doing. Very, very important if you look up and see what the small brain does. If the hand here is along the baby's neck, that interferes with the movement of the cervical vertebrae, the vertebrae in the neck, 7 vertebrae in the neck. And that means that generally the average hand on a baby, this part of the hand rests on the 7th round, the 7th cervical vertebrae, and that sets off the baby to want to hyperflex its head, deflex the head all the time, like that. So, and if you're pushing the baby, it's like us being pushed to our dinner plate every time we eat. It is most uncomfortable, most distracting when a little baby's trying to feed. So that's a really good reason to avoid using the cross cradle technique if you can. And that's in my experience. And other people will say that's not so, and I accept that. But in my experience, it's a very common problem when you understand what the neurological responses to all of those things are. Now, you can use any hold you like at any time you like. The football hold, or the hold we use for twins, is really important that you have your hand open, that you don't use your pad of finger, pad of thumb here on the baby's head. You don't hold their neck and their shoulder. Just use your hands as a little pillow. And so they're free to move on your hand. So lips over nipple, all the principles are exactly the same. Baby coming to your breast, on your side. Maybe you need to rest the baby on a pillow at your side, maybe not. Doesn't matter if the little baby's bottom, depending on the size of the baby, is resting, you know, on what you're sitting on, but depends how long the baby is. That's individual. Lips over nipple, and so the baby does the work, draws the nipple and the breast tissue, and then there's face to breast symmetry following that. And fine tuning is exactly the same, slightly back, slightly forward for nose and chin, nostrils on the breast, pointed chin in the breast, and tilting the hand slightly over or slightly under on the upper shoulder and under shoulder to get the cheeks of the breast. Very, very important. So any hold that you like is okay, it's comfortable for you. The reason I would be using different positions around the breast if I had someone coming to me is for blocked areas of the breast. So if the breast was blocked out here, most definitely the chin in the region, not over necessarily the exact spot, but within the region and symmetrical at the breast means the chin and the tongue will work that part of the breast, and the chin and the tongue in here work in harmony together, and they bring that milk that's been stagnated there down through the ducts and out through the nipples. So down through the ductal network and out through the nipple ducts. So if it was, for example, and I've done this several times, where it's been high up here and the mother's been sitting in a chair, we pop the baby and one of us support the baby over the shoulder and down this way, and the chin works in the top of the breast. Now, babies actually feed really well. It's quite amazing. So under your arm, over here, and then cradling if it's here, and lying down if it's underneath, And same principles again, face to breast symmetry, really, really important. Thank you. So I'm told by my team that that's it for this week. If I've missed your questions, please submit them. Do we submit them again next week, or we just answer them again next week? What's the?
Yeah, they can just enter their questions and we'll put them in for next week.
All right, please submit and we'll put them in up the line for next week. If there's anything that's really urgent, you can talk to my team and I might be able to communicate with you. I can't do that for everybody, it's just not possible. And also, but if there's something urgent, I can. If you have a long question with lots of points in it, then I'm more likely to be able to answer that better if I can answer you in writing, rather than trying to cover all the points in this 1 hour, about 1 hour session. So that we can get all the questions that are coming in, so we can get them in. It's harder. So I may respond in writing, and I hope that's okay too.
Message us through the page.
Yeah, and you can message us through the page as well. If my team will look after all that background work for me, and then they'll advise me that someone has sent this and someone is concerned about this and so on. And the questions that are coming in while we're speaking, I try and answer those if I can. If I've missed one, I truly apologise for that and hope that we'll cover it next time. So for those that are birthing, happy birthing, be strong, listen to yourself. You'll be the wise woman and you'll know exactly what to do, and your team around you will support you. Transitioning through pregnancy, into labour and the stages of labour, early labour, pre-labour, early labour, established labour and breastfeeding are individual transitions for every mother and her baby. So beautiful breastfeeding. Thank you.